Yes.
Ready?
Yeah.
Enable the
So I'm ready. But I think to enable my screen sharing option.
okay, sir.
Can I start?
Later on, we can minimize this.
Sure.
To see whether your slides are moving.
Yeah. Yes.
Good morning and welcome to this very special session on one of the most important aspects during this terrible pandemic that we are a part of. And to help us with this, we have Dr. Manesh. He's one of the young rising stars in the national horizon in the field of infectious diseases. He did his undergraduate and postgraduate training at the Christian Medical College, Vellore, and was the one of the two people chosen as the first batch for the DM in infectious diseases. He is a clinical academic focusing on antimicrobial resistance, and his research interests span different areas, but he's looking at novel approaches to the management of neurological and serious multi-drug resistant infections. His recent research activities include the evaluation of the Milwaukee Protocol for aggressive treatment of rabies encephalitis and TB meningitis. His most recent peer-reviewed publication was on the viral escape of HIV in CNS and invasive fungal infections. He won several awards and grants, including the Cedric Global Meeting in London and the RSTMH Travel Grant for Research Training in TB meningitis in the Oxford University Clinic Research Unit at Vietnam. He was CMC's best outgoing postgraduate trainee in internal medicine in 2014. He won the special award in nephrology during his training and also was awarded the gold medal, the P.H. Chandrasekhar gold medal, which is a prestigious gold medal in infectious diseases during his training in 2012. He also won the Kutumbaya gold medal for excellence in clinical medicine, which is given for the best student in the batch. His current roles include he's the organizing secretary of the Infectious Diseases Postgraduate CME. He organizes the adult vaccination workshop for CMC. He's faculty of the Fellowship in Global Infectious Diseases course funded by the US, which is held in CMC. Antimicrobial stewardship workshops. And that is how I got to know Abhi so well, because he does such a fantastic job. And he trained one of our people whom we had sent for training to CMC. Most importantly, Manesh is one of those gems as a human being. And we're so glad that he accepted our invitation. Abhi, we have people seated in the hall ready to ask you questions. And we are going to follow whatever protocol you teach us, because we are just at the beginning of the stage where you were at the beginning of June. Cases have started pouring in, and we want your guidance, guidelines as to how we manage patients of COVID-19. So over to you, Dr. Manesh. thank you once again very much for taking up this challenge and setting aside time for us in your extremely busy schedule. I know that 4 o'clock you go into the COVID ward and you're there till 11 o'clock every night. And thank you for giving us this time.
It's an absolute pleasure and privilege to be here. So thank you for this opportunity, sir. And what we will do in the next about 30 minutes is to look at broadly the core principles in clinical management of COVID-19. So one thing I have focused in this brief session is that we will focus on things that are quite evidence-based. Of course, policies might change from place to place. We will focus on where there is clear evidence, what are the core principles, so that we can sort of modify it to the need wherever it is required. So essentially, I'll start off with a case. This is a gentleman, 39-year-old, presents to casualty with fever, cough, severe fatigue, nausea, no comorbid illnesses. He seems to be an occasional wheezer, and he takes inhalers. His vitals seems remarkably okay, and so these are his tests. His basic tests all appear normal. Total count is within normal limits, and his nasopharyngeal swab is positive for SARS-CoV-2. So essentially, he has a mild COVID-19 COVID-19 infection. He's symptomatic, but there is no evidence of pneumonia or hypoxia, and his respiratory rate is within the normal limits. So this is the most common scenario we would see. And what to do in these people? So the first thing is, depending upon the local guidelines, you might be mandated to admit them, or you could carefully monitor them in home isolation. So regardless of what approach to take, the most important thing is to monitor the saturation and ensuring they are okay every 6 daily. Now, therapy is unclear at this point. We know that a lot of therapies have been touted around, but if you look at the role of hydroxychloroquine, it's very clear that it doesn't work as a therapeutic agent or post-exposure prophylaxis based on RCTs now. Also, there's not much evidence for favipiravir. There's only a single RCT from Russia. Didn't change the viral clearance at the end of 2 weeks. In that, role of ivermectin and agents like colchicine are based on some case series showing marginal benefit. So other thing is that we like to give anticoagulation in these people, prophylactic anticoagulation. The important role is restricted to people who have already traditional risk factors, who we would anticoagulate if they get admitted in a hospital, like people who are elderly and people who have comorbid illnesses, severe comorbid illnesses restricting their mobility, people who underwent recent surgery, and obesity. These are the traditional risk factors where we would anticoagulate people routinely. Those are the guys who actually require anticoagulation if they get admitted with mild COVID-19. So most of the management is predominantly symptomatic, looking for any severity features if they develop, and to address them accordingly at this point. If you look at the other important question is that, can we predict guys who will become severe from mild infection at admission itself? There are several scores that have been used. If you look at the scores that have been developed, about 5 of them are there, but not very useful at all in our clinical practice if you look at it. And of course, the guys who are elderly, especially people who are more than 60 years of age, and these 3 risk factors are really prominent risk factors. Those who have cardiovascular disease, obesity, and have some form of malignancy, in addition to diabetes, hypertension, chronic renal failure, smoking, etc. The test one could do to predict severity are the neutrophil lymphocyte ratio, C-reactive protein, D-dimer, LDH, ferritin, and IL-6. Unfortunately, most of the tests are not able to predict people at the upfront. So if somebody is going towards severe disease, you will document a trend towards a neutrophil lymphocyte ratio shifting more than 4 or 5 and CRP climbing. But if you ask me that, can I predict if they come with a mild disease at admission, if their CRP will be elevated, they are at higher risk for going into the ICU or going into some NIV ventilation? That's not true. So that's the catch. Some evidence that there is a blood group predilection, but it's not very clear yet. So current scores, mainly clinical evaluation, somebody becoming more breathless, and the high risk factors are this age, comorbidities, and these specific risk factors which I had showed you. Now, if you look at Ravi, over the next 2 days, he becomes breathless. There's worsening cough, predominantly bedbound. He becomes tachycardic, respiratory rate increases. He drops saturations and develops lung findings. Now, he definitely has a severe COVID pneumonia, isn't it? So, in this thing, the broad approaches are three. One is we need to find strategies to tackle the virus. We need to use antivirals. The second important thing is that it's very clear the virus elicits a dysregulated or exaggerated immune response, and that needs to be modulated in some way for optimal outcomes in COVID-19. The third thing is the spin-off effect of this virus, immunity, and the inflammation that results from it. So you have issues like thrombus formation, which need to be addressed. So if you remember these three, these are the basic principles in managing any severe COVID-19. Of course, there is a component of critical care in severely ill patients, which I will not be getting into in this presentation. So just to get a sense of what I said about the host inflammatory response, if you look at clinical severity, initially the viral loads are quite high in patients with COVID-19, but the viral loads tend to come down as they progress into the illness. Then what you see from this is the weekly basis, this is the first week, the second week, and after. So if you look at the second week, from then on, the host inflammatory response takes over and is responsible for many of the organ manifestations, lung involvement we see in COVID-19. So this is just to give you inside view of what happens to the immunity during COVID-19. So if you look at the, let's go one by one. So if you look at the T cells, the B cells, they dramatically drop because they are hyperactivated, exhausted, and some of them even undergo apoptosis. This is the reason for the neutrophil lymphocyte ratio going high in severe disease. And you see that the D dimer starts climbing slowly, inflammatory markers like CRP, ferritin starts climbing, the antibody levels start rising, and this is the pink one is the viral RNA copies. They initially peak and then sort of starts to come down. So this is what happens if you take the COVID immune response as a whole in somebody with a severe COVID-19. Now, the antiviral, the only antiviral that has been shown to be useful in COVID-19 is Remdesivir when used in patients with lower respiratory involvement. It's an it inhibits the RNA polymerase in the virus. It has a good safety profile. And what it showed in this large trial is that it clearly reduced hospital stay and produced a trend towards lower mortality at the end of 2 weeks. Initially had availability issues in India, but now Remdesivir is widely available. This is the trial data which I talked about, showing that Remdesivir had a clear outcome benefit at the end of 14 days. Now, how to use Remdesivir? So the important trick to use Remdesivir appears to choose your patients early and put them on Remdesivir. So you need to consider Remdesivir upfront on people with prominent lower respiratory involvement. many chest infiltrates, any borderline drops in saturation. So this is very likely to be most beneficial in patients with early hypoxia. The benefit appears to be less once they are on NIV, high flow oxygen, or intubated. This is because presumably the immune response to the virus is driving the pathology there. So start early in patients with prominent lower respiratory involvement. The only thing is that probably two caveats to remember is that you need to ensure liver enzymes are okay. What is okay is less than 5 times the normal. And also, if somebody is on antiretroviral drugs or anti-epileptics, one need to be watchful whether there is any interaction with Remdesivir. So those are the things. Otherwise, it's a very safe drug to administer. Infusion-related issues and all are very minimal. So the antiviral strategy part of it, this is the one drug, and we should administer it early in patients with lower respiratory involvement. Now, how to reduce hyperinflammation in COVID-19? So, as I showed you, exaggerated immune response, there is disease pathology. Now, how to address this immune response? Now, should we use a targeted blockade? You would have heard of tocilizumab and things like that being used, or should we use a pan blockade like steroids, which sort of suppress the immunity generally, but may not truncate one particular limb of the immune arm? So this also shows the same thing. So as your immune response goes up, you have higher risk of moderate disease, and slowly towards death, your chance goes up. Now, what has been shown to be clearly beneficial is to give a overall immunosuppression to these people. So this is the recovery trial, which looked at lots of patients. If you look at the numbers here, we are talking about numbers like 6,500 patients from UK, and randomized them into usual care and dexamethasone. The dexamethasone group received 6 milligram IV OD of dexamethasone for 10 days duration. And what they showed was definitely dexamethasone helps. And the benefit is even larger among people who went on into a ventilator. That means that the earlier phase, Remdesivir seems to be useful. If somebody develops a severe organ damage, lung damage, requiring support, then steroids definitely have a role to play. See, if you look at this, the way this graph splits off, no, it appears that you have a persistent dramatic effect of the drug and protecting from mortality clearly in this data. If you split the data, it looks like steroids don't work for patients who do not require oxygen in the early phase of disease. If you use DEXA at that point, you might delay viral clearance. So you don't want to delay viral clearance there, but you definitely want to use DEXA on the guys who are requiring oxygen and also who go on to develop invasive or non-invasive mechanical ventilation. That's the subgroup analysis from the same trial clearly demonstrating the same. Now, this is an entity that has come up with COVID-19. So like any respiratory virus, even if we take flu, when there is severe flu, there is a lot of inflammation and increased cytokines, lung damage within the lung alveolus. If you see the right side of the image here, what this produces is these elevated thrombogenic cytokines like IL-6 produce microthrombi formation, which sort of block the circulation. So it seems to be a concern in COVID across multiple studies, but it's difficult to decide who needs anticoagulation. So one another question could be that how to pick out those guys who require anticoagulation. Can we use something like D-dimer, which is a breakdown of fibrin product, or something else? Platelets can be used, PTINR can be used. So the correlation is not that clear. While D-dimer can be elevated in most patients, the relationship is always not linear, and all patients with thrombus may not have an elevated D-dimer. Thrombocytopenia is also uncommon, and elevated PT, APTT also very unusual. So the strategy is that somebody who has no symptoms or mild symptoms, don't anticoagulate them for COVID sake. If somebody has severe disease or moderate to severe disease with pneumonia, start them on prophylactic anticoagulation as if they are at a higher risk for thrombosis. Now, who needs therapeutic doses or escalated doses? The risk of thrombosis during COVID is around 5 to 20%. Now, not everybody we can do an image, microthrombi may not be visible, and practically doing an image may not be feasible in many settings. So the potential candidates who you could use elevated doses of anticoagulation, or people who have a sudden respiratory or hemodynamic deterioration suspicious of an embolus, and also oxygen requirements disproportionate to the chest X-ray, and clinical suspicion of DVT, and those with very high D-dimer like more than 1,500. So these are the guys who we can consider for a escalated therapeutic anticoagulation. So let's just go through anticoagulation alone. I'll just summarize: mild, no anticoagulation unless like they have something that requires prophylactic anticoagulation like immobility issues. Moderate to severe disease, anticoagulate them, give them prophylactic anticoagulation. Among that group, a small group might require therapeutic anticoagulation if their chest X-ray and their hypoxia is out of proportion, like an embolus, or you have clinical evidence of DVT, sudden respiratory or hemodynamic deterioration, and very high D-dimers. Now, let me just touch upon two experimental therapies because they have sort of been talked about quite a bit in COVID. One is the IL-6 blockade for cytokine storm, and the second one is convalescent plasma. So, the cytokine storm was an entity that has no clear definition. Essentially, a lot of cytokines getting into the bloodstream typically was used in CAR cell therapy for cancer. But in the early time from China, there are reports of cytokine release syndrome when people had high fever, suddenly had worsening lung infiltrates, and went on into a ventilator, and a good majority of them succumbed. So that's when they felt that cytokine release syndrome is a problem. This led to therapies targeting IL-6, which is the main cytokine involved in cytokine release syndrome, with IL-6 inhibitors like tocilizumab. So let's just look at that because that's an area which is often talked about. So if you look at the absolute levels of IL-6 in patients with non-COVID ARDS and also COVID ARDS, you just run with me. So if you look at the table here, the IL-6 level, even in severe COVID-19, is here. But you look at it, the ARDS, regular non-COVID ARDS, the levels are far higher. So it appears now, it looks like the IL-6 levels may not be that high in COVID-19 for us to jump and block it. So even if you look at the Convacta trial, which is the only RCT, large RCT in tocilizumab, it did not show any difference in clinical improvement, death, or ventilator days in patients with severe COVID-19. So this is the Convacta trial data. The data has been published by the drug company itself. It did not show any improvement in any of the factors that was studied, except there was a delay. There was an earlier discharge in the tocilizumab arm. Except for that, this was the main outcome studied in the trial. There was no difference in the clinical improvement at all. Now, why targeted blockade is not useful? I tend to think of it like a spider web. When we block once or you tear off one limb of this web, there are other strands that hold the web together. So cytokines are much more complex. They are very, very interdependent. So if you block one pathway in a cytokine loop, there are other pathways that will likely take over. And mainly elevated IL-6 might just mean that the immune response is very severe. That doesn't mean that IL-6 is doing everything and we can block it and get away with it. So that's what it looks like. So currently it appears that there is no role for tocilizumab in patients with severe COVID-19. Our second intervention is convalescent plasma. This is an interesting intervention because you sort of give passive immunity. So you take people who have recovered from COVID-19, ensure they don't have active infection by 2 swabs taken 24-hour apart, and you collect their plasma and give the plasma. There is a small risk of transfusion-related acute lung injury. So you need a ABO compatible plasma about 200 ml transfused. So the efficacy has been very questionable. It's been still studied in 2 RCTs, small RCTs, without any benefit. Case series claim that there is a fantastic recovery. So it's overall not clear. We need more data to use convalescent plasma much more widely, definitely as an experimental therapy in a trial setting, but not for regular routine patient care. But it does appear like a safe intervention if you look at it from a safety perspective. Okay, so it appears safe, the efficacy is not proven, needs more data, and probably if at all you want to consider convalescent plasma, it should be given rather early and before people go into mechanical ventilation. A good number of people already have very high antibody titers, so may not be reasonable to giving them more antibodies. It might produce more harm than good. So this is the last slide. Let's just look at the summary of how to manage a severe COVID-19. Of course, you need the team, the critical care and acute care physicians who can manage hypoxemia very well. And you need antiviral strategies like Remdesivir. You need pan-immune blockade strategies like steroids, and also you need to consider prophylactic anticoagulation if there are no contraindications. More than this, other treatments would be probably experimental within the purview of a clinical trial. Thank you.
Abhi, thank you so much for that exhaustive lecture on where you are, where we are with the knowledge or understanding of treatment. Can we just get some clarification from you?
Please, sir.
So we want to ask you, it is now clear from what you taught us that the earlier we start treatment, the better.
Yes.
Okay. So you've said that if the oxygen saturation drops to below 94, now we have people who are now that level 1 kind of thing. So are you suggesting that when the oxygen saturation drops below 94, if the respiratory rate goes above 24, we will immediately start steroids and Remdesivir? Is that what you're advising?
Yes. So if there are clear lung infiltrates and the oxygen saturation tends to go down, they are developing some sort of a respiratory compromise, that is the time to consider something like Remdesivir, definitely, subsequently steroids as well.
Okay. And how, can you just help us with how do you differentiate a cytokine storm from other COVID symptoms? Are there guidelines on that? Is there a way we can make it?
So the cytokine storm as a phenomenon doesn't seem to be a clear entity in COVID-19. So I think for practical purposes, we need not factor in the component of cytokine storm or try to address it in a different fashion. Yes, there is a dysregulation in immune response, which we are trying to address by initiating steroids appropriately. But the cytokine storm per se doesn't need a separate addressing.
Okay. Abhi, once again, on the HCQs, I know there's been a lot of up and down things. The recent ICMR data suggests that we must use it. Would you
Yes.
help?
Yes. So that's something I made clear. What I suggested was on the basis of evidence, what we have for the particular intervention. The evidence at this point appears to be quite weak after 4 randomized trials, but we might use it depending upon the local guidelines or the government-specific guidelines in any particular area, conforming to the guidelines at that particular point. But what I'm saying is that the benefit is likely to be small.
Abhi, is there any source for Remdesivir? What does CMC do? It's quite expensive, no?
Yes. The Remdesivir, the total dose comes around about 25,000 rupees. And there are multiple players in the market who have brought down Remdesivir and also cheaper versions of Remdesivir with equal efficacy also are coming out, which will bring down the cost of Remdesivir at least by 1/3 is what it looks like. The way I look at Remdesivir is that if you take the cost of hospital stay for somebody on oxygen and the drug can reduce it by 4 days, the impact of that intervention is quite profound. So early usage can really help is what I was thinking.
There's a question that's come online, Nabi. Patients who have lung infiltrates, after the patient has recovered, will there be long-term damage? Do we have to manage that afterwards?
Yes, so this is becoming a problem that people have persistent symptoms after COVID-19, especially restricted to the lung. So it looks like about 2/3 of people have some sort of persistent trouble, some cough, some lung involvement, lung fibrosis after a severe COVID pneumonia. It definitely needs follow-up. We don't know much about the overall prognosis, whether it will become better, whether they'll develop a permanent lung fibrosis. We don't have clear information on that, but it looks like this is something we will find out more and more about. What you said is absolutely true. It is an area of clear concern, and any hospital that has a large volume COVID care facility should plan for post-COVID care and have some form of way that they would get in touch with the system if there are problems. Yes.
Abhi, you've said that we use dexamethasone. Can we use methylpred? Why is dexa preferred?
Sure. So there are a few things. One is that, of course, you could use methylprednisolone in times when you want to avoid dexamethasone, like in situations like pregnancy, you could go for methylprednisolone. The distinct advantage of dexamethasone are two. One is it is a much more, a stronger immunomodulatory effect than methylprednisolone. And the other thing is there is very little fluid retention with dexamethasone compared to other steroids. So if you have a lung that is already damaged, you don't want it to be waterlogged as well. So in that perspective, dexamethasone may have an advantage, and dexamethasone is the drug that was studied in the trial. So all these put together, we prefer dexa, but in situations like pregnancy, one would prefer to use things like methylpred.
Abhinav, you said it should be given intravenously. It always has to be given intravenously?
No. So we could start with intravenous when somebody is sick and always change it over to oral. Only thing is when we use dexa salt orally, the dose will be about 8 milligram dexa rather than 6 milligram, which when given over IV preparation. Yeah.
Okay, and it's always given as a single dose?
It's a single dose, yes.
Okay. Now, from your experience, Abhi, patients whom you are managing, particularly the staff you are managing, how long do you keep them? Do they have to be admitted as per the Tamil Nadu rules?
Yes. Currently, as per the Tamil Nadu rules, everybody who has a positive test needs an admission. So they come in, and once they are asymptomatic for at least 3 days, provided from the time of testing it's 7 days over, they can be discharged.
Okay.
Then we give them a...
Sorry, go ahead.
Yeah, then we give them a 2-week quarantine period. So totally they come out of hospital, then there is a home isolation where for 2 weeks, and then they return back to work. There is no re-swabbing or checking whether the virus has gone, because the virus tends to stick around for a long time, even many months. So that's not recommended for both for patients or doctors who are affected with COVID-19.
So are you doing the CT levels regularly, and are you using that for your treatment protocols?
Yeah. The cycle threshold levels in the PCR, there are a lot of issues with it. Some of them could be that the way you take the swab is going to really impact how your CTs and how much is the transfer time, waiting time, all those is going to influence your CT values. So generally people would sort of suggest against using CT values as a marker to go one way or the other.
And do you follow up? You said up to day 14, they're in quarantine. Now, patients who are away from you, do you tell them to keep in touch? Because there are reports of uh, recurrence, or, we don't know what exactly is happening, but patients getting unwell again or testing positive again. Do we have some clarity on that?
Yeah. So there is a group of patients, probably less than 5%, after admission, after discharge also develop symptoms, even requiring hospital admission. It looks very clearly that it's not a reinfection, but the current infection lingering with an exaggerated immune response, because it typically happens within the first 2 weeks when they are in the quarantine period most frequently. So in that situation, we reinitiate therapy with steroids, remdesivir when they come in ill. So definitely they are clearly told which number to contact, how to come to casualty, which is the area dedicated for COVID care, how to enter and how to report themselves. That has been explicitly told to them. Yeah.
Okay. Abhi, can I just request you to once again just go over? Now, we are now admitting patients. Okay. Now, can I just go over that with you? That we watch for a drop in oxygen saturation. We watch for respiratory rate going up. So we'll have monitor both these on a regular basis. And the moment it drops below 94 or the respiratory rate goes above 24, we will start steroids. Is that right?
Yes, and remdesivir as well.
And remdesivir, both these. Azithromycin has no role anymore.
Azithromycin doesn't seem to have a clear role.
Clear role. Now, at what point do we start anticoagulation?
So if somebody is sick enough to come on oxygen and on any severe disease status, some oxygen requirement or requires NIV, definitely they require anticoagulation. And if their D dimers are very high, we can even give them therapeutic anticoagulation, because it appears very difficult to shift them for anything imaging and all that once they are coming inside into a COVID area.
Okay, okay. So from your experience of the 850 patients that you have now on a daily basis, how do you manage the patients who have other major comorbidities?
So
How do you plan that?
that is a serious concern, because you have many people coming for something else completely, and in the hospital they seem to be, when they are coming, they develop some symptoms, or even on routine testing they might pick up to be COVID positive. So it needs to be a collaborational care with the COVID care team, along with the primary care unit definitely involved, because the COVID care team may not be familiar with the exact ways of treating the primary disease. Some of them are quite ill with the primary disease rather than the COVID itself. So it's a care as a collaboration between the two units, and you have typical levels of care drawn. So level 1 is mild. If there is any escalation from level 1 to level 2, immediately it requires expertise at a higher level, people who are familiar with managing sick COVID or looking at that patient, and things are taken in that direction as well. So essentially two factors, having a clear level and also very clear collaboration between the primary unit for the primary problem plus the COVID care team.
So do the teams go together for rounds to manage or?
Yeah. So one of the trustees of this COVID is the interruption of our norms of care, that people cannot go in together in large numbers, and there is issues with infection control, PPE. So the way it's devised is that one senior member from the primary team will make all the major decisions, and if the patient needs to be seen, they will be seeing them and they will be updated regularly. The COVID care team will be responsible for the ground level care of seeing them regularly in 2 to 3 times a day and ensuring whatever is required is provided.
Please. Can faculty sitting in that hall please ask your questions?
Dexamethasone, why it is so powerful? It is actually compared to the cortisone, it is 32 times more potent. That's why it is used. Dexamethasone. That's one of the why dexamethasone is preferred. Another thing to that Dr. AP, the speaker, is regarding the viral load and complications and mortality. Copies of the viral load, how it is correlated with the mortality.
Sure. Thanks for that comment. Yeah, I agree. Dexamethasone is more potent than methylprednisolone. And regarding now, we have clear emerging data that people who have higher viral loads, especially people who have some already pre-existing compromise in their immune system, either because of their age or they have on some immunosuppressive medications or some something that suppresses immune system like cancer, have a higher viral load. The higher viral loads clearly correlated with the poor outcome.
Can you have, but it is essential to measure the viral load.
Yes. So the most of the tests we use is a qualitative test, giving a positive or negative result is what we get. But if you look at the cycle threshold values, if your cycle threshold values are less than 18, then you are most likely dealing with a very high viral load. And if your cycle thresholds are very high, then the number of copies the PCR machine has to run to detect the sample positive is high. So the baseline viral load is very low. So you could make some presumptions on the basis of cycle thresholds, but I'm not aware anybody quantitatively measuring clearly the viral loads. This is the common one that is used.
What is your experience with the Favipiravir?
Yeah. Yes. So Favipiravir, the mechanism of action is very similar to Remdesivir, and the Indian government has also given a conditional approval to use Favipiravir routinely in patients with mild disease. The concerns with this drug is we don't know whether it acts very well. If you look at the RCT that came in clinical infectious diseases last week, the RCT tried to look at whether Favipiravir will decrease the viral loads dramatically at 2 weeks in people who receive. So it didn't actually. So we don't know whether Favipiravir as a drug changes things, but currently in our national program as well, there is a conditional approval saying that we are awaiting more data to see whether this drug works effectively, but the data seems to be at present a bit shaky. Sorry, I'm not able to hear.
I know in Vellore as a protocol you're not using HCQs, but as trial basis, are you using a particular set of patients? Are you giving them HCQs to see your experience?
Not currently. They basically the HCQ has been withdrawn from the two largest trials, recovery and also solidarity. We were part of the solidarity trial, but it got discontinued early because there was no benefit with HCQ in their experience in their arms. So we are not using it as a part of the trial as well now.
So were you also part of the solidarity trial to start?
Yes.
Thank you.
Thanks.
Thank you, Abhishek, for your very good. Thank you, Abhishek, for your very good presentation on the COVID management. What I was concerned about was the asymptomatic carriers. So, this is there a situation like that, and will they be spreading the disease, or is there any role in treating them or finding them?
So definitely asymptomatic carriage is a problem in COVID-19. Depending upon the population we are looking at, whether we are looking at elderly people, younger people, we could say that about 20 to 30% of the people may be actually asymptomatically infected with COVID-19. And can they spread the disease? Yes, there is clear evidence that asymptomatic carriers can spread disease. Now, the trickiest part is what you asked. Can we treat them? So, one is identifying them is difficult because unless we go around swabbing people, we might not pick up people who are asymptomatically infected. And we don't have a clear intervention that dramatically works in people who have mild or asymptomatic disease so far. So, yes, we might use HCQ, we might use favipiravir, but there's no clear evidence that they dramatically remove the virus.
But these patients admitted, many of the asymptomatics are admitted and they are discharged also only after doing the test. So is it just reliable enough, or can we just discharge it?
Sorry?
We can be, these patients are admitted, asymptomatic COVID positive are admitted. When they are discharged, maybe after a week, we don't use the test, just discharge after 2 weeks like that, or 2 weeks the test.
So Abhi, the question is it safe to do that?
Yeah, okay. So it appears perfectly safe because if you look at people after 8 days of mild or asymptomatic period, nobody seems to have a viable virus if their swabs are cultured. So after 1 week, there's no viable virus sticking around, especially in mild or asymptomatic people. So that our government policy appears very reasonable that to discharge them after that because they are no more transmissible. And also the government is very clear that you are discharging into a facility where they are self-isolating for 2 weeks. That means they are wearing a mask. They are in a single room. Ideally, they use a separate toilet. Their utensils are kept separate and they are away from other members of the house. So practically, it appears to be a very good strategy to contain transmission.
Thank you. Very clear. Thank you.
Just a quick question. Regarding steroids, is there any time frame you keep the patient on steroids? This is because there is a long-term sequelae, especially with regard to the lung complications. So how long would be the ideal course of steroids? Is there any case for a long-term steroid administration in these patients?
Currently, the recommended duration of steroid use is 10 days. This data is from the recovery trial. Whether there is a use for steroids, see, one of the problems is that if somebody is sick enough to be hospitalized for COVID for more than 10 days, usually they are requiring some sort of an organ support. And if you are ventilated or if you are on an NIV with good dose of steroids, then your risk of hospital-acquired infection also starts climbing significantly on a high dose of steroids. So one needs to sort of balance that against giving a longer course of steroids. So 10 days, yes, but more than that, I don't think there is real evidence to say that you need to give more. People are actually looking at, can we cut this 10 days to even shorter, so that the exposure to steroids is about 5 to 7 days, and then we can wind up.
And how about neuropsychiatric complications of chronic fatigue syndrome that comes in?
Sorry?
Any neuropsychiatric complications and chronic fatigue syndrome? What is your experience with these
Yeah,
patients?
so my experience is rather limited with post-COVID care, but there are reports of multiple neurological manifestations with SARS-CoV-2. You could have something like an encephalitis, Guillain-Barré syndrome. As you rightly mentioned, there seems to be a component of chronic fatigue syndrome that takes off in the first few months of post-COVID. But these syndromes are, I feel, increasingly recognized now, but we will know more and more about them as time goes by.
Thank you, Dr.
Yeah.
Abhi, do you have any guidelines for people, I mean, pregnant women who are COVID positive? How do we manage them at the time of delivery?
Yeah. So my particular experience in that is limited, but in what I know, pregnancy doesn't seem to have a worse outcome when there is a COVID infection, unlike in direct contrast to the flu, where pregnant women, if they develop flu, we expect a very poor outcome. They seem to be doing rather well. And the children are rarely infected. Even if a pregnant woman delivers with COVID-19, the children are usually safe. But there are protocols developed by the obstetric and pediatric team in here. I'm sure they can help to develop something similar there as well. But I'm not exactly involved in that care. These are the things I know.
Jancy?
Thank you so much. You have made it clear regarding a patient admitted with COVID that after testing, tested positive for 7 days and then discharged and 2 days quarantine. But if it is a patient who needs to come back into hospital, like for example, with a semi-urgent surgical case, something which can wait but still needs to be done as early as possible, when surgeons ask, what should we advise them?
So the simplistic advice would be that if the primary condition can permit, 10 days after the stoppage of the clinical illness for mild disease and 20 days in severe disease, you can take them up for a semi-emergent procedure. But in the...
For mild disease and 20 days for a severe.
This, what I am saying, is the CDC guidelines. But if, let's say, somebody has an urgent indication requiring surgery or anything, they can be straight away taken even during their COVID infection for their care if it is urgent.
Another scenario is a dialysis patient. They have been tested positive, mild disease as far as COVID is considered. So 7 days finished, but they have to come back into dialysis unit thrice a week. So is it acceptable for them?
In that situation, what I would suggest, if feasible, is that not to discharge them to home quarantine, but keep them in a single room isolation facility for the entire 21 days, 7 days of mild illness plus the quarantine period, and do regular dialysis. And after that, don't swab them because they will be likely positive, but discharge them and ask them to come with regular patients for the COVID, post-COVID time for dialysis.
Thank you, Epi. Thank you for that.
Abhi, when at the end of 21 days, when you swab them, the CT value will tell us, no, whether they are infective or not.
Yeah, the trouble we find practically is that if you're positive, immediately the government mandates admission. So they come into the system again, then they go through quarantine and all that. It's a loop that goes on and on. So that is the fear with retesting and all that.
Okay, thank you. Any questions from the faculty? Are you all okay?
Are you looking at possibilities of for your staff to, because Dr. Priscilla was just mentioning about antibodies, I think it's coming for validation or something. So are you looking at seeing if they're actually immune, if they have IgG in them, or those the nurses who are COVID positive already, when they can come back for work into a COVID ward? So are you looking at the possibility of antibody estimation in them?
Yes, we are doing studies among the hospital staff, how their antibody responses are, but we have not reached a place where I can say, I also don't know what is the exact data. There are this thing going on, but nothing completed enough to say that this is the result we have.
But Abhi, overall antigen testing you are not doing at all, no?
Yeah, we are not into antigen testing predominantly for the reason that it has a lot of false negative. So, though it's very quick and easy, a good number of people it can miss. So, our strategy, what we have stuck to is once you're suspecting, you remove them from the general population, admit them in a suspect ward, and swab them and ensure they are negative by PCR. PCR has its own problems, but that's the best we have.
Abhi, do you have any advice for us in terms of helping our staff not to get infected? Do you have any? I know the mask and the hood that you have. Is there anything else we can do? See, because our biggest problem is this, that asymptomatic patients in the ward or somebody suddenly turning positive, they might have gone to the market or something and
Yes.
come. So is there anything we can do?
There are two things that I want to say. One is that the infection per se, with the regular use of PPE, what is recommended for clinical care is practically close to zero. There is no transmission within the hospital if appropriate PPE is used. But the transmission will happen outside the hospital because all of us healthcare professionals also would be involved in many other things. This is multiple people have looked at that and showed that the infection in healthcare workers also mirror exactly the community. And the prevalence of infection, active infection mirrors exactly with the community. So it looks like there are events that will happen outside the hospital or even within the hospital in a coffee area or things like that, which would be the transmission zones. But if there is adequate PPE use, I would be even I know that in our COVID area, which we are sustaining now for almost 4 months, barely any infections in the healthcare workers who are working there, because particularly because you're very cautious and you're on everything when somebody is suspected or confirmed.
Would the same be true for the theater as well?
Yes,
Anesthesia?
it is true. It is true for even high-risk environment like anesthesia, close to airway involvement, the PPE appears to be absolutely safe.
Thank you. Dr. Elizabeth James?
Sir, I would like to ask, what advice would you give our transfusion medicine blood bank department regarding this convalescent plasma? Would you ask us to stock it, and how do you collect convalescent plasma?
So Dr. Joy Moman and Dr. Snehil are the people who are involved in doing the convalescent plasma in CMC. So I'm sure they will help you with the protocols and things like that when required. But in what I know, the simplest thing is somebody who has recovered out of COVID, regardless of whatever type of infection they had, mild, moderate, or severe, you take them in after at least 2 weeks of resolution of clinical illness and ensure they are swab negative and then collect their plasma. They will be able to help you with the exact ways of going about it. Dr. Joy Moman, I'm sure you can get in touch with.
So Dr. Abhimanish, thank you very, very, very much for a beautiful presentation, taking us through the whole thing and answering all our questions. So when we do well, we'll give all the credit to you. Thank you very much. Thank you.
So much. Absolutely.
Whenever we have doubts. Thank you. Thank you. Is Sunita here?